Hello, everyone. My name is Sharifa Ahmed Hamid, a professor and consultant neurologist from Asyut University Hospital, Asyut, Egypt. I'm going to demonstrate an important but under-recognized and understudied topic in our locality, which is the sexual function in women. My topic for today's meeting is the sexual function in women with focal epilepsy and its relationship to their demographic, clinical, hormonal, and psychological variables. In general, I have no conflicts of interest. Epilepsy is a known, frequent, and chronic medical problem with a high incidence rate of 1 to 3 per 100 persons. Patients, whether men or women, are at increased risk for sexual dysfunctions, whether symptoms or disorders, and estimated to be 5-fold higher than that for the general population. And previous studies reported a prevalence of different aspects of sexual dysfunctions in women with epilepsy to vary from 14 to 60% or even up to 95% compared to up to 45% in the general population. As all we know, sexual life is important for the good quality of life. Women with epilepsy may experience different aspects of sexual dysfunctions, which include few sexual experience, sexual anxiety, problems with libido, erectile dysfunction, painful intercourse, orgasmic dysfunction, and inadequate orgasmic satisfaction despite normal desire. The causes of sexual dysfunctions with epilepsy is multifactorial. Previous studies indicated that the major cause of reproductive and sexual dysfunctions are the pathophysiology, the biological and endocrinologic factors associated with epilepsy or as adverse effect of its medications, particularly anti-epileptic drugs, which are enzyme inducers of hepatic enzymes. However, some suggested an association between sexual dysfunctions and psychological variables. Feeling insecure, stigma of epilepsy, low self-esteem, self-isolation, negative influence for search of a partner, and therefore avoidance of situations that call for effective sexual involvement. Our aim for this work is to determine the frequency and severity of sexual dysfunctions, whether global or subtypes of sexual dysfunction in the interictal period in a group of women with focal epilepsy, and to detect the predictors for these sexual dysfunctions. In this study, we included 120 females married with epilepsy, and also we included 60 matched healthy married women for statistical comparisons. All were studied in the interictal period. Females with focal epilepsy of unknown etiology were only included in the study. They all should be on regular treatment for at least 1 year on anti-epileptic medications, whether carbamazepine or oxcarbazepine, and all were married and had regular sexual activity with a husband. All underwent neurological, medical, urological histories and examinations. We evaluated sexual function using a familiar sexual function screening tool. We did psychiatric interviewing for all patients, and we screened all for depression and anxiety manifestations using common screening scales. All underwent lab investigations, including measurements of levels of prolactin, total testosterone, sex hormone binding globulin, which were done during the follicular phase, which is the cycle day 1 to 6, and we calculated the free androgen index. Table 1 showed the demographic and the clinical characteristics of patients. All patients, whether on carbamazepine or oxcarbamazepine, were similar in age to the control subjects. They are highly fertile and they have chronic epilepsy, and included patients either having temporal lobe or frontal lobe epilepsies. And they all were on treatment with carbamazepine or oxcarbamazepine as monotherapy during the study period. And the majority were moderately or partially controlled on anti-epileptic medications. We found high frequencies of global sexual dysfunction and its subtypes, whether the desire, the arousal, the lubrication, the orgasm, satisfaction, pain, compared to control subjects. And we observed that the patient on carbamazepine, on oxcarbamazepine, had less frequent manifestations of sexual dysfunctions. This table showed the severities of sexual dysfunctions in patients with anti-epileptic drugs. It also showed that compared to control, although patients in general had high severities of sexual dysfunction and its subtypes, but it is less for carbamazepine, for oxcarbamazepine compared to those on carbamazepine. The laboratory characteristics of patients showed that patients on oxcarbamazepine had higher levels for total testosterone and lower levels for sex hormone binding globulin and lower free androgen index, indicating favorable laboratory or hormonal profile for patients on oxcarbamazepine compared to those on carbamazepine. Also, the psychological characteristics showed that patients on oxcarbamazepine had lower mean values for the depression and anxiety screening method, and also they have less frequent severities for depression and anxiety compared to those on carbamazepine. Multiple logistic regression analysis, which we did for patients to determine the only significant independent predictors for sexual dysfunctions in women with epilepsy. It showed that the only predictors were the psychological variables, which are depression and anxiety symptoms, but none of the hormonal variables, demographic or sociodemographic characteristics are predictors for sexual dysfunction in women with epilepsy. In this study, the results of this study showed that the sexual dysfunction is common in women with epilepsy and highly frequent. And this is the first study which was done in our locality or even on women with epilepsy. There was only one study which was done on men with epilepsy and treated with oxcarbamazepine. However, the studies for sexual function in patients with epilepsy are frequent, but the strength of this study is that it is the first study which was done on women with epilepsy, not only in our locality, but also the only study which was done on women and treated with oxcarbamazepine and compared their results with those on carbamazepine. In this study, as we said, we found that women with epilepsy had approximately 2 to 3 folds higher frequencies for sexual dysfunction compared to healthy women from the general population. Different aspects of sexual dysfunction were involved, like lack of desire or arousal, dryness, dyspareunia, poor orgasm, sexual dissatisfaction, regardless to the type of epilepsy. We also observed that oxcarbazepine therapy was associated with better seizure control, higher testosterone level and free androgen index, and lower sex hormone binding globulin level. Also, patients on oxcarbazepine had less sexual dysfunctions compared to those on carbamazepine. We observed that the only predictors for sexual dysfunction in women with epilepsy and regardless to the hormonal profile, which was improved with oxcarbamazepine compared to carbamazepine. These predictors are depression and anxiety manifestations. And we can suggest that oxcarbazepine therapy is associated with favorable profile for sexual dysfunction and favorable psychological profile due to better seizure control for women with epilepsy compared to those on carbamazepine. We noticed that our prevalence showed some difference from other reported from previous studies, and this variation could be explained by the different studied patients population and different definitions and questionnaires utilized for screening. Our recommendations from the work are: physicians should optimize seizure control by adjusting the anti-epileptic drug dose or its modification to alternative anti-epileptic drug for better seizure control, which is required to improve sexual function for women with epilepsy. We can also recommend that individualized psychotherapy or pharmacotherapy with antidepressants or anxiolytic may be needed in some women with epilepsy, and future longitudinal and large sample sized studies have to be done on different population with epilepsy, on different anti-epileptic medications, including the new anti-epileptic medications. for better understanding of the exact pathophysiology of sexual dysfunction in women with epilepsy. Thank you.